Let me start by welcoming all of you. I'm very happy that you took the time to join our webinar and to listen to our stories about public engagement in the context of COVID-19. I will now start sharing a short presentation to introduce this webinar. My name is Frank Kupper. I am Assistant Professor in Science Society Interactions and Public Engagement at the Athene Institute of the Vrije Universiteit Amsterdam. The Athene Institute has a mission to contribute to a more fair and sustainable world by connecting science and society. So, for example, by engaging citizens, different groups in society, early in the research and innovation process to align the course of these processes with societal values, needs, and interests. So that is what we are working on in different areas and domains: new technologies, global health, the participation of patients in research and care, sustainability, just to name a few. This webinar is a part of a series called Transdisciplinary Responses to a Global Crisis. It is the one before the final one. Next week, we will have the final webinar, which is dedicated to the public debate about COVID-19 in our societies and the way citizens make sense of the complex reality of COVID-19 that they are facing and how to respond to that. So if you like, please join us next week as well. But for now, let's move on with the introduction. I just changed computers because upstairs my connection was not working. One of the consequences of the pandemic is that we have to rely on our own resources more. So the two pictures that I found this morning are not here. Now I switch back to my laptop. Anyway, what is this picture about? It is about the public outcry that we see more and more regarding the COVID outbreak and the outbreak response. So our Dutch famous opinion poller Maurice de Hond started an initiative called Smart Exits, following the disputable claim that the Dutch government launched a smart lockdown instead of the general lockdowns that we saw in other parts of the world. So this initiative, Smart Exit, got a lot of traction, and this Sunday afternoon in The Hague, a lot of people gathered to express their concerns and their needs for the exit strategies to be, the exit measures to be released so they could live their lives like normal again. So this is the context that we are now in. And in the past months, especially in the beginning of the response, a lot of people said there isn't time to do engagement. Now we need a fierce response. We need to listen to the experts and make our decisions based on the available evidence. We don't have time to set up a consultation or a dialogue with citizens. We have to act now, and we can evaluate later. But is that true? I think in this webinar, you will see that there are actually countless opportunities to do public engagement also in this situation. Catherine writes, who is affiliated with the Nuffield Bioethics Council in the UK, has put it like this: if it's not acceptable to argue there isn't time to do community engagement in recent Ebola outbreaks, then it certainly isn't acceptable to argue that there isn't time to involve patients and the public in UK COVID-19 trials. Another UK expert on public engagement, Simon Durrell, said what we actually need are more people worrying about wider challenges related to easing the lockdown and how we involve the public in resolving them. But why do we actually need public engagement? First of all, the outbreak responses and exit strategies have implications for different groups and individuals and societies, implications that deeply impact their lives. So it is their democratic right, you could say, to have a say about it. Second, effective outbreak responses rely on the cooperation of everybody. So they can only function and be effective if there is enough public trust and support. And we know that engagement is a mechanism that can increase trust and support. And thirdly, members of different publics have valuable knowledge and perspectives to share to help guide and improve outbreak responses. What should we be engaging about? Well, there are a lot of trade-offs made all the time in the decisions that are taken, but also the steps in research and innovation that are done in moving forward in the outbreak response. Public health is weighed against other public values that are at stake. Here you see a few of those. So you have to look at the health of individuals with different risk profiles and maybe treat them differently. What about the psychological effects of lockdown on people, on young people that are growing up and need social interaction? Of course, the capacity of the healthcare system has been an important parameter for steering the outbreak response. But all vulnerable individuals and groups and their interests should be taken into account. There is the financial situation, the economic situation of individuals, but also of countries. What about our freedom of movement and freedom to express ourselves and to express what we think is really important? Think of the anti-racism protests, etc., etc. All these trade-offs are made all the time. And the question is, who should make these trade-offs and whose voice matters in the deliberation of these trade-offs? On top of that, the problem is wicked. Like many other challenges that we face, the COVID-19 outbreak has some destabilizing features in the sense that we still don't know a lot about the outbreak and about the implications of the measures. The stakes are high and the decisions are urgent. And values, even though we all value our health, we all value public health, in a more subtle way, values are still in dispute. So what we need is, first of all, greater transparency about evidence, also about the decisions that are made and the processes of decision making, and a better understanding of a variety of impacts that take place. So these are goals that public engagement maybe can contribute to. But we also need a confrontation of different knowledge backgrounds and value perspectives in the deliberation of these trade-offs, which means that we need deliberative engagement. And the question is how to do it and where to connect engagement to research and innovation processes and policy making, and also intervention. So you can think of different domains of the decisions that are made in policy and politics, the development of intervention strategies and technologies like the contact tracing apps that are developed, the production of knowledge about not only the effectiveness of interventions, vaccines, but also knowledge about impacts on different individuals and groups, and the practice of healthcare. Now, today in this webinar, we have different presentations for you to explore each of these different aspects. One of them will be done by Sophie Kemper, a PhD student at the Athena Institute and at the Dutch Institute for Public Health and the Environment. She will be talking about engagement in outbreak response and outbreak management. We have Liedewij Vat that will be talking about public engagement in research. Liedewij is also a PhD student at the Athena Institute with a focus on patient and public involvement. And we have Carina Pittens. She's an assistant professor at the Athena Institute, and she will focus on engagement in the practice of healthcare. So we will now start with the three presentations. After each presentation, there will be some, and sometimes also within the presentation, there will be some interaction involved with you, with our audience. And after the presentations, we will share some more general discussion questions to engage in our discussion of public engagement together with you. Let me now welcome Liedewij Vat to talk about public engagement in research. Liedewij, please take over.
All right, welcome everyone. Good morning, thanks for joining. So my name is Liedewij Eva Vat. I'm indeed a researcher and lecturer at Athena. I've worked on implementing public and patient engagement in Canada as well as in the Netherlands, and I'm currently looking at how to best evaluate patient and public engagement. I'm using both terms, but please feel free to substitute the term whatever fits in your context. So I know that involvement is also used, or participation, but I'm using public and patient engagement in this presentation. So today I will talk about COVID-19 research. How can the public be engaged and when? What is the possible impact? And I will show you a few examples. But first of all, I would like to engage you, starting with a polling question. So I will ask you to answer these two questions, and I will launch the poll now. So the first question is, do you think it's possible to engage the public in all aspects of COVID-19 research? Do you agree? Is it possible? If you agree or disagree. And the second question is, in your opinion, to what extent is public and patient engagement happening in COVID-19 research? I know that we also have people from various countries on this webinar, so perhaps in the discussion we could share a little bit what we see in different countries. But now I would like to just get a general impression of what you see and what you think. So I see that people are answering. I'll give it another few seconds to see what's happening. Okay, interesting. Last call and polling. So I can share the results with you now. So most of you, but 60%, so not everyone, thinks that it's possible to engage the public in all aspects of COVID-19 research. But some of them disagree, so perhaps we could have a chat about that later on. And then some of you are seeing some small examples of public and patient engagement to some extent, even 20% saying to a moderate extent, but there are also some people saying it's not happening at all. So if you have seen any examples, then I encourage you to also share those in the chat. So please feel free to share those. I will also share some examples, and then towards the end, we perhaps can have a brief discussion and share our thoughts. So thank you. That's interesting to see. What are we actually talking about if we're talking about COVID-19 research? Now, first of all, what we have seen is a massive investment in this type of research. So there has been a massive global response of the research community. A lot of money has been raised, and there's a lot of money available for corona-related research questions. Now, the question is, whose research questions are we trying to answer? If we look at the types of research that has been funded, that we're seeing that mostly drug-related intervention type of research is funded, looking for treatments, of course, looking for a vaccine to benefit the whole society, but also treatments to benefit those who have symptoms of COVID. We see quite limited funding for non-drug-related interventions. And recently, we have seen that some funding is starting up for the more economic and societal consequences of COVID-19 and the measures taken. For example, people who have lost their jobs, but also societal consequences for people with, for example, non-communicable diseases, those who have perhaps a chronic disease and have experienced delayed care. What are the consequences for them? But also think about mental health consequences. So there are a lot of other groups in society who may have questions that they want to see answered in research. So we see a shift in the current research priorities that were out there, a shift in research agenda, and a massive investment in COVID-19 research. This is a quote that comes from an open letter from a group in Ireland, Murphy et al. And they express the situation in Ireland, and I think that's also something that we are seeing in the Netherlands. If we look at the decision-making context, and we see that the expert voice dominates the discussion, and that a lot of decisions are taken on a central level. We have seen that a lot in pandemics, and that there's not a lot of time, so there has to be a very rapid response. So that is the complex context that we are in, and the decision-making situations that we are currently in. And that is putting pressure on patient and public engagement, because how to engage the public if it has to be fast, and if those groups are not really established, because it's a new disease, it's a new situation that we are in. So there are not really established patient engagement groups, for example. There is a risk in this as well. There's a risk that due to the time pressure and the non-existing infrastructure that we may see some research waste, and this is something that we are seeing actually also before the pandemic. This is a figure from Chalmers and Glasgow out of 2009 actually, but we're still seeing a lot of research waste due to questions that are not relevant to patients and clinicians, poor research designs, not fully accessible results, etc. So there is a chance of research waste, and by engaging the public, but also other knowledge users as clinicians, we can also better listen and create a system that is very needs-oriented. So when can you then engage the public? There are plenty of opportunities. I will highlight just a few. As I started with, in prioritization, we're seeing a lot of centralized priority setting. But still, research funders can encourage, for example, the applicants that apply for public funding to engage the public in designing research questions. So there can still be some engagement in priority setting. There can also be engagement in reviewing, in this case, publicly funded research. For example, reviewing research proposals. You could have a public review committee. Not something that I have recently seen in the Netherlands, but it's definitely possible, and we have seen it in other countries also in other situations. Then it's possible to engage those with lived experience in designing and managing research, because those knows best how treatment will impact their lives, how treatment will help, but also how to design interventions, what works, what doesn't work. So all those experiences are super valuable in designing research. And then in undertaking research, that's often a bit of a difficult step. We've seen actually examples of research projects that are hiring people with lived experience. Now, most of us have an experience with COVID-19 to some extent, but also, for example, think about peer-to-peer interviews, people with experience interviewing other people, that may also work quite well. Then, of course, very important, involving the public in dissemination. So how to reach the public, what are best channels, what language to use, how to formulate the key messages, how to implement the results of research, what works, and in the end also, of course, evaluating impact. So what are the key indicators that we should focus on? In the Netherlands, we are talking a lot about a dashboard that should monitor how we are doing. So what are those key indicators that should be on the dashboard? I'm also looking at a quick look at the chat. I've seen that some people are already sharing some examples, and there's also someone who have raised their hand. Esther, do you want to perhaps ask a question or share your thoughts here?
Sorry, that was just a raise hand by mistake. I wanted to type something in the chat.
Oh, no problem. Please do so. But also for others, please feel free to raise your hand if you have a question. And I think we can collect them then and make sure that they are answered, because I like the kind of interaction. For time, because we have a lot of presenters, I will just continue. I like to share this slide, also created by Murphy et al., as they looked at the essentials for engagement in pandemics. And I think it nicely summarizes what you need to engage patients and the public in pandemics. Especially you need, of course, investments, but it also requires to build those long-term relationships and to have an open, transparent relationship when planning pandemic research. It requires, especially in pandemics, creative and flexible approaches. So we have to work with online tools to engage people, and that may offer opportunities to engage actually more people than perhaps in a normal setting. But we also should be aware, of course, that not all have access to internet or computers or may know how to use them. So it also limited engagement of some more vulnerable groups. So it's a challenge there to be inclusive and also to be sensitive of the situation, especially those who are in quarantine, those who are having a chronic disease. So there are a lot of extra challenges that should be taken in account in pandemics. I worked a lot recently on the impact of engagement. This is for a project called Paradigm, looking at meaningful and sustainable patient engagement in medicines research and development. Athena is a partner in this project, and we're working with a lot of pharma companies as well as European patient organizations and researchers. And I recently published this paper who looked at the impact of engagement. It's open access, so you could have a look at it. I won't discuss it all. I want to highlight a few. In pandemics, I think one of the key things that is important is the enhanced well-being that those who contribute can gain from engagement. You have to imagine that people with perhaps relatively mild symptoms are staying at home or have to stay at home, and that can be quite have an effect. So having a meaningful thing to do and to contribute to their community may enhance their well-being, may give them a meaningful task during the day. So that is something to take into account. As Frank also shared, it's very important to also think about hope and trust in research. That is something that is a huge impact, especially thinking about vaccine development. We have seen in previous examples that public engagement is key, especially if you want vaccines to be taken up by the society. So early engagement is really important in those kind of research areas. Another one that I want to highlight is the increased transparency and accountability, especially for research funders. As I started with, there is a massive investment in research right now, but we need to ensure that we use those resources wisely and that there is transparency in how those resources are used and who will benefit from that. So there are a lot of benefits, but there are also some challenges. And of course, there are benefits for the research process, creating a more needs-oriented research, answering questions that matters, creating better designs, etc. So lastly, I like to show 2 examples. There are many more, and as I said, please feel free to share that in the chat box. I kind of like this example. It's an international initiative. There's an international steering committee looking at the core outcome sets for COVID-19 research. The group is called COVID-19 COS. You can find more information on their website. But what they have done, they looked at literature, they created a survey, and they asked a lot of health professionals and patients and the public of what they find important to measure. What you see, for example, is a lot of studies are looking at the viral load, but that may not be the most important thing for patients to see as a core outcome. So they looked at what are the things that are important to measure. And I think they are about ready. They just completed workshops and they're about ready, I think, to share this core outcome set. So keep an eye on their results. Another example, which may be nice to share, this is from Australia, the Telecom Kids Institute, and this is Anne McKenzie. She is a manager there in community engagement, and she and her colleagues rapidly created a national advisory group for research related to COVID-19. So creating actually that infrastructure, creating that access for researchers to quickly connect with those with lived experience and to engage them in research. And they have already started running multiple virtual sessions. They discuss multiple topics, all kind of research. It's a very diverse group, so it's a kind of interesting initiative. Now, as I said, there are many more. Due to time, I will not share all those examples, but if you're interested, these are just a couple of resources that you could have a look at. And if we have time left, then in the discussion and in the chat, I would love to see your examples, but also perhaps missed opportunities. And we can discuss how to create that constructive co-production landscape in a situation where there is a shortage of time. And of course, also, how can we ensure that also the most vulnerable groups are represented? So that are still some questions that we need to answer together. I will have a quick look at the chat and at Frank, and then I think we continue with the next presentation.
Yes, thank you very much, Liedewij, for your presentation. Oh, can you keep that last slide on, please? Yeah. Thank you very much. Let's see whether there are any responses right now. So if there's anyone that would like to ask Liedewij a question about what she has just shared, raise your hand. I will try to zap through and see whether there are any hands raised. I don't see any. And I thought maybe it would be a good idea to already start sharing examples of public engagement in the chat now. So we can use them for the discussion later. But I would like to, collect them already.
Yeah,
so,
I've seen that there are some examples already shared from Ireland. Thanks for sharing that.
Yeah. ihealthfacts.ie. And so this is a question for everyone. If you have examples of public engagement in COVID research, please put them down in the chat now, and we can come back to that later.
Okay.
Liedewij, I have a question. Because I was wondering, in the Netherlands, I think the most famous health research funder, ZonMW, they are, at least in my opinion, quite actively stimulating that patient participation and community engagement in their funding decisions. Did you find any, because they have a lot of course, calls on COVID-19 at the moment right now, did you find any is there any engagement there happening at the moment? Do you know?
Yeah, I looked for that, and it's quite difficult to find. So I'm not feeling comfortable to say certain what is really happening. We have seen in the Netherlands that the most research funding started with rapid response research and with a lot of research on transmission, etc. What I have seen, for example, in the Netherlands is that parents had questions whether it was safe to send their children to school, and what the effect was of COVID on children and their transmission. And as a response to that, we have seen in the Netherlands that the Dutch government has funded some research looking at the consequences of COVID-19 for children and the impact of getting, having children going back to school. So we have seen those examples. I've seen that ZonMW in their call for proposals has a sectional stakeholder engagement. It's not super specific of what the requirements are there, but yesterday actually they have shared a very nice newsletter which I included in the resource section with a lot of examples actually of engagement. So you definitely see some attention, but it's not really strong in requirements, and I haven't seen any public review committees.
Yeah.
But if any others on this, in this webinar have seen any examples of that in the Netherlands, then please share those. I have not been involved in any, but we have submitted a proposal and obviously aim to engage the public.
And what is then your view on like, do you think at the moment, because you've then been involved in writing a proposal, which all had to be done really fast and last minute, and I probably can imagine that you would of course run into yourself into a barrier. Oh, if I have to engage the public right now in writing this proposal with a deadline in 2 weeks, that would be tough.
Yeah.
What is your
good question. Yeah, I experienced it in my own hands how difficult it is, but I believe that if there is a will, that actually in this situation rapid response is possible. So I managed within a week to get 4 public partners on board, to have calls with them in the evenings, early mornings, to share the proposal with them. Obviously, I would have liked to more co-create a proposal, having perhaps a call all together. We didn't manage to do that yet, but I have seen actually that people are really willing to contribute because it is really affecting them directly. Yeah, but indeed it is a challenge and it requires a lot of flexibility.
Yeah.
Okay.
Thank you. Interesting.
Thank you so far. I suggest that we now move on to the next presentation. And to mark this move, I already put into the chat an example of public engagement in outbreak management and the choice between different exit strategies and measures. Our PhD student Sophie has done some actual research into what citizens themselves think about public engagement. So in the COVID-19 response. So Sophie, could you please share your first results? I mean, this research is still in the making. So I think it's very exciting that we already can get a sneak preview into this. Can you share what you have encountered?
Yeah, of course. Good morning, everyone. I'll share my screen. So now everyone can view the presentation?
Yeah.
Yeah, okay, I see some people nodding. Yeah, so my name is Sophie Kemper and I'm currently working on my PhD at the Athena Institute and also at the National Institute for Public Health and Environment, at the National Coordination Center for Infectious Disease Control. And as Frank said, today I'm joining this discussion because a few weeks ago I talked to the citizens, to the Dutch public, about involving the public or involving Dutch citizens in the management of COVID-19 in the Netherlands. And so today I will share some insights with you that I gained from the study. So a quick background on my PhD project. I started last year in September, and I'm trying to figure out, or I'm trying to come up with a strategy for the embedment of patient and public participation in the management of infectious disease outbreaks in the Netherlands. And to do that, to figure this out, I was planning to execute several case studies. So looking at different outbreaks that happened in the Netherlands in the past, and well, just analyzing the outbreaks and talk to patients and talk to the public about how the outbreak went and if they see any opportunities for public and patient engagement. So I was working on this, and 5 months into my PhD project, the COVID-19 outbreak started. So then we decided that this would be one of my case studies. And now this was also my first data collection experience, which was of course very special to me because it was my first, and it was in the midst of an outbreak, about the outbreak. Yeah, so I'm looking forward to share some of my insights with you. So what did I do exactly? I performed several online focus group discussions. I performed 3 focus group discussions at the beginning of June. So the outbreak situation in the beginning of June, as you can see in the graphs, the upper graph displays the number of deaths per day. So as you can see, it really declined compared to the beginning of the outbreak when I executed the focus group discussions. And also the number of cases, the graph below, number of cases also declined. So as I mentioned before, we did 3 focus group discussions. The first focus group discussion, we executed it with 4 participants between the age of 18 and 45. The second focus group involved 5 participants between the age of 46 and 65 years old. And the third focus group, we executed it with the elderly, 65 plus years old. And we actually divided the focus group discussions into 2 parts. So in the first part, we asked the participants to create a timeline of their experiences with the outbreak from the start of the outbreak until now. So we asked them about meaningful events or meaningful memories that they still can reminisce. And we asked them to write the events down. And of course, we did a little discussion on the events. I will also share some timelines in the next slide. And in the second part of the focus group discussion, I gave a little bit of background information about the outbreak management in the Netherlands, especially from the perspective of the national public, the RIVM, the National Coordination Center, how they manage an outbreak like the COVID outbreak. And after this, we had a discussion with all the participants about if they saw opportunities for public involvement in the outbreak management. So as I said, the participants created some timelines. So this is one example of a timeline from one participant. So for this participant, her first meaningful memory or her first meaningful event was that her physical therapy stopped. So in the beginning, she got this information from a call from her practice. And in the beginning that she found the whole situation, the whole outbreak situation, a little bit laughable. But very soon it became a lot more serious for her because all the physical therapy practices closed down in the Netherlands because of the outbreak. And as she has a chronic condition, it was really, this was a really big miss for her that her physical therapy stopped. So this was one of the first events for her. And in the second timeline, another example, I asked the participant about what his most meaningful event was during the whole outbreak, from the beginning until the end. And he shared that his most meaningful, well, what was most impactful for him was the phase in which the restrictions of daily life began. So he elaborated that he had to work from home and the school closed, and that were all measures that really impacted him in his daily life. So a lot of different things were happening at once, and he also explained that one way or another, everyone was being involved in this outbreak. If it was indirectly or directly, doesn't matter. A lot of things were happening all at once. So this was a little bit about the results of the first part of the focus group discussion. So now I want to share some insights about the second part, about the discussion on involving the public. So all the participants feel like that the citizens should be involved one way or another. It was quite difficult to figure out in what way exactly they see it happening, but they see it happening. And as Frank said also in the beginning of this webinar, the participants shared that in the beginning of the outbreak, they don't feel like that citizens can be more involved than only informing them. Because at this moment, the outbreak is happening, is taking place, swift action has to be taken, a lot of measures has to be taken, and you don't have a lot of time to make decisions on these measures. So they said, we don't think you can just only inform the citizens about your measures, but you can not really involve them in the decision making. So this quote supports this feeling. When you have to control a virus, every day counts. I think in these types of situations, you really have to rely on the expertise that is already there, not only expertise that has yet to be established within the public. And the subject expertise is also something that came back quite a lot. So the participants feel like, I lost my mouse. Yeah, there it is. So the participants, general feeling of the participants was also that they could rely on the expertise of professionals, and they also should rely on the expertise of the professionals. So the quote backs this up. At the end of the day, I assume that the experts are the ones who made the right decisions and you will follow them. That was also interesting for me to hear, of course. And yeah, later on in the outbreak, they think there is more of a place for the citizens to be involved in outbreak management. So at that moment you can consult or even involve the citizens, because at this moment the outbreak is of course more manageable and you have a little bit more time to involve the citizens and to ask for feedback. And yeah, they specified on asking citizens for feedback. So this quote, an important role you can fulfill as a citizen is that of a soundboard. So when a certain decision is close, you can ask citizens for their feedback, questions and struggles. So before making the decision public, you can anticipate on these questions and struggles. And at this moment, currently it is not happening and you see that things are going wrong. So, and the word feedback, that, yeah, they said it several times during the all three focus group discussions. So I think that would be something to analyze even more, or to ask about even more what ways of feedback is exactly meant in what they said. And yeah, a little bit of elaboration on the feedback. The government or the National Institute Coordination Center, they can maybe even prepare scenarios with the public to anticipate the reaction of the public on certain decisions or certain measures or certain information that the government gives out. And that is more of the consult side. And about involving citizens, one participant came up with sort of an umbrella structure. So he used the example of the measure of school closure, and he suggested that the government would work together with the schools, so the branch organizations, to discuss with them if and in what manner school closure would be an option. And in their turn, the schools would discuss with their teachers, students, and parents of the students how the school closure could be put into practice. So he said, in this manner, you can talk to the branch organizations and to the citizens about a subject of which they are knowledgeable. Of course, the teachers, students, they have experiential knowledge. And he said the role for the public institute would, for example, be to facilitate these kinds of discussions with the branch organizations, between the government and the branch organizations. So this was one concrete example of how he saw how you could involve citizens in managing the outbreak. Yeah, and this, when opening the discussion on the outbreak to create public support, is also something that came, that also Frank said in the beginning. It was one of the arguments for public engagement, and that was also something that the participants felt. So when you open the discussion and you give feedback on why certain measures are taken, why certain measures are not taken, you create a public support base. And that is also, of course, important in citizens to take up the measures that you give out. And this quote supports it. If you give people the feeling that they made a decision together with the government, that will create a lot more goodwill and also a support base for that decision. Yeah, so I think that is it for now. That is what I wanted to share about my research, about my study that I did. And I also prepared some discussion points, and I can share them with you for now. So what I got back, the feeling that I got back in all three of the focus group is that the participants, or maybe even the public in general, they don't really view themselves as someone with expertise or someone who is knowledgeable about an outbreak. So how can they then be involved in outbreak management if they don't have any expertise on it? So that is something that came back multiple times. However, what we are talking about today is that they, of course, have experiential knowledge with the situation. In this study, it is, of course, the outbreak situation. And I was wondering if you guys have any experience with it, if you also felt this numerous times in your study, or if you can say something about this, how to deal with this as a transdisciplinary researcher. Should you, for example, make this explicit to your participants or to the public? Or should you just let them figure that out for themselves in one way or another? So I think that was my first discussion point. So maybe we can first discuss on that. And after that, I have also another discussion point if we have time for it.
Okay, thank you very much, Sophie, for your presentation. I was also present at 2 of the 3 focus groups you did, and indeed, this point was also, one of the point you raised now, one of the striking points, and that we as a public engagement community may see the importance and also the need for public engagement beyond informing and consulting, to also deliberating about the trade-offs that are made, as I introduced. The citizens that we spoke to sometimes actually seem to distrust other citizens even with this task. So it would be really interesting to hear other opinions of the people in this webinar about this. So is there anyone that would like to share? I'm not able to see all screens at once. So if you, Sophie, if you can
stop share?
Stop sharing.
Yeah.
So are there any responses to this points that that you would like to raise? Yeah, I see there a thumbs up from PPI Ignite.
So my name is Edel Murphy and I'm from Galway in Ireland. And I'm very interested in all of the points raised so far. And I suppose drawing on our experience here, I would very much agree with the two people who have said that the public are very willing to take part. I think the researchers and the clinicians were all, you know, rushing to the table, very invigorated and really wanting to do something. But there was a perception that, you know, our vulnerable, and I put that in quotes, public and patients, you know, wouldn't look at the challenge in the same way. Whereas in fact, with our existing, we call it involvement, public and patient involvement contributors, they very much wanted to put their shoulder to the wheel in exactly the same way. Probably the only weakness maybe we're waiting to be asked. So maybe as time went on, they began to say, well, I won't wait to be asked, I need to put myself forward. And I think that has been an interesting kind of movement in the thinking of existing people. So I suppose the time question is obviously very pertinent because we tend to take things more slowly. And the big message I've taken from it is the importance of having good involvement processes in normal times, so that then when the crisis occurs, that we have people who understand what involvement is about and who are ready to get engaged in whatever is required. So I think the onus is on us all to build those relationships and build that capacity in researchers as well as in our involvement people. And then going back to Sophie's comment about, you know, how can we get people to think about doing things differently? I think in normal business, we all have a tendency to use the straightforward methods, you know, the focus group, you know, maybe a little bit of, you know, we call them yellow stickies, post-its up all over the place. And I think there's a huge onus on us as an involvement or an engagement community to constantly try to develop more innovative ways that we are all familiar with, you know, because we work on them in good times, that then we can draw on in times of need. So I think the challenge for each of us is, rather than continuing to do involvement in what's maybe a bit of a cliched way, that we need to be always trying to improve the way we do that in normal business, so then we can draw on that in times of crisis. That has been a big learning for me. Thank you.
Thank you. Thank you very much. There are two points in your story that, I can really connect to, and that I also hear in the stories of Liedewij and Sophie. The one is about existing structures. If you have structures for public and patient involvement in place, it is much more easy, but also much more effective to involve publics and patients in times of crisis. And the other one relates to that people also have to put themselves forward and actively become part of it, which of course goes back to the argument about existing structures. I saw another hand raised by Mitzi.
No, that's just a thumbs up, Frank.
Okay. Just a thumbs up. Sounds good. I look at the time, it's already 10:30. So I suggest that we move on to our third presentation now, which will be delivered by Carina. So Carina, can you please start sharing?
Yes, good morning, everyone. I think you all see my slides now in place.
Yes.
Well, after the very interesting talks of Frank, Liedewij, and Sophie, I will take the discussion into a slightly different direction. I would like to tell you something, to talk to you about engagement of patients, clients, and care professionals within care in the broader sense of the word, where you see that all those people really make, with relatively small gestures, a huge difference for patients. My name is Carina Pittens, and I work as an assistant professor at the Athena Institute, where I study engagement of patients, clients, and care professionals within, for instance, care practice. In the next 10 minutes, I would like to introduce you into engagement in care practice. At the Athena Institute, we have a long history in studying this topic, and I will shortly tell you more about our research in this specific field and about our theoretical approaches to study engagements. And you will see in a few slides that I have formulated a fairly broad definition of engagement in care practice. Thereafter, I will shift towards COVID-19. In many of our current research, we see tremendous impact of COVID-19. Of course, much impact is negative, but also beautiful initiatives came up. What can we learn from it? During my talk, I would like to invite you all to think along with me. Have you seen initiatives of engagement in COVID-19? Have you seen initiatives of engagement in COVID-19 in care practice? From small gestures to huge initiatives like new collaborations, the creation of a COVID-19 home, etc. Please share them throughout this talk in the chat box. And if we have time left afterwards, I hope we can discuss with each other a bit more about these initiatives. Well, first, how can we define engagement in care practice? Sophie, Liedewij, and Frank, they all shared their view on engagement. And I have defined it as follows. Engagement in care practice implies the inclusion of all relevant actors, including patients, clients, carers, and care professionals in active decision-making processes, which means that all those actors actually can have influence in the decision-making process. And to me, engagement is a means to an end. So I would say that the aim of engagement is for care practice to improve the quality of care and life of patients. However, there are multiple ways to reach this aim. So I have listed four for this talk. The first one, engaging patients and clients on an individual level, often referred to as shared decision-making. Second, engaging patients, clients, carers on a more collective level, often referred to use their experience to improve care or policy or research in general. You can think about client advisory boards, for instance. Third, and that's something we will talk through more elaborative, new ways or different ways of collaboration of care professionals, often referred to as integrated care or working in networks. So instead of working in silos, care is more often organized around the patient in itself, which means that individual professionals and the organizations they belong to have to join forces and work together. And you cannot do this without proper engagement of care professionals. And fourth is taking the initiative or the responsibility to actually making a change. So it requires leadership of individual care professionals, of patients, etc. So at Athena, we actually studied all those different ways. For now, I would, sorry, that's a bit quick. For now, I would like to elaborate a bit more on a few current research projects which have a focus on more inclusive collaboration in elderly care networks. And with inclusive, we mean that all actors, including the care professionals and the patients, actually have a say, having influence on the decision making. They have to join forces and work more closely together to realize, for instance, more patient-centered care. And on the right, you see in Dutch a few titles of our current research. For instance, in Hilversum, a town in the middle of the Netherlands, we study how professionals from different organizations in the first line, like general practitioners, nurses, physiotherapists, can work more closely together to provide the best possible care to vulnerable elderly living at home. And they do that from the notion of positive health and re-ablement. And that's entitled Maak de Burgemeester in Hilversum. In Friesland and Groningen, two northern provinces in the Netherlands, we recently started a 2-year action research on the structural embedment of geestelijke verzorging. I searched on the internet, but I was not really able to find a proper translation for geestelijke verzorging, but it means it's related to mental care workers. And for this structural embedment, close collaboration with professionals in the medical, social and welfare domain is essential. And within those researchers, we saw very interesting things related to this COVID-19 times, but I will come to that later on. What we do within those researchers, we study engagement collaborations from multiple theories and concepts. I have listed several on the sheets. I won't explain these concepts because it would take me an entire webinar, but I just wanted to show you that to us, transdisciplinarity not only means that we want to involve everyone that is affected by the care in this, in this matter, but that we also combine several viewpoints in order to truly understand what we are studying and to realize change. So a few of the theories and concepts we use in our collaborations research are system innovation, patient and professional engagements, the concept of leadership, integrated care networks, boundary work theory, and the concept of good quality of care. And just one sheet in which I try to visualize system innovation. I just want to emphasize that we have a holistic approach. In our research, we take several levels into account, from niche to landscape. And we explore how niche experience, small pilots can be scaled up, but also what kind of influences the landscape or the regime level have on those experiments. And you can apply all those different theories and concepts I just told you about within this broader picture of system innovation. So what we actually see in our research is that COVID-19 has had major negative consequences. However, we also see some beautiful initiatives, not only in our research, but also popped up in the media every now and then. And these initiatives, they range from relatively small gestures to make a difference for one or maybe several patients and clients, like being creative in realizing visits to elderly in nursing homes, as depicted on the left bottom, to huge collaborations like transforming an empty nursing home location into a COVID-19 home, where people who are actually not sick enough to go into the hospital but cannot stay at home can be nursed, can be cared for. And on the right bottom, you see a picture of a location from Miriant in Heerenveen, that's in the northern of the Netherlands, where they actually built within a week a COVID-19 home. How can these initiatives be explained? Before COVID-19, also many efforts were made to realize collaborations or to stimulate initiatives by professionals for those clients, but many challenges were faced. Why are some initiatives now accelerating or happening seemingly without much effort? I believe many explanations are in place. I've listed a few on this sheet. Well, if you have any additions or other thoughts, please share them in the chat box. What we see actually is that COVID-19, and that's also something that Frank explained earlier, has created a new environment in which much is unknown. There was and still is no one best way, and not much is already embedded in those rigid structures, processes, and cultures. So professionals could experience more freedom to act accordingly to what they consider the right thing to do. Less is protocolized, for instance. Moreover, and that's also something Frank explained, COVID-19 could have created a sense of urgency. The impacts are major, and there is a strong desire to act quickly and soon. So what do we see in our current and our own research? Well, actually in all of our research, and I've mentioned just two of them, but we have more, of course, we have seen that collaborations between organizations, between professionals, between informal and formal care have been strengthened. Between professionals from different organizations and with different specialties. They all stress that they can find each other now more easily. They just pick up the phone more easily. They reach out without any thresholds. Also, and that's what I meant with the previous example of the COVID-19 home in Miriam, that's actually from one of our researchers. We have seen major collaboration around, where organizations and their professionals collaborate to provide the best possible care. In the COVID-19 home in Heerenveen in Friesland, I think like 5 organizations were involved. They all said, we are going to do this together, and we will deliver care professionals from our organizations. They don't know each other. They are not used to work with each other. And within a week, they actually built a COVID-19 home and were able to establish a kind of routine together to provide that care to the COVID-19 patients. So what helped them? I just listed a few ideas. What popped up in our minds when we were discussing it with our research team is that within this complex time, the organizational and professional interests are less important. Everyone is working for the same cause. They have a community feeling, we are going to do this together. And also what helped is that the unfamiliarity, so there are less structures and processes and cultures in place. They are actually creating it on the spot. And then I have no idea about the time, sorry, yes, I still have. We also see initiatives on a lower scale, so more from directed to individual patients and clients, but what actually makes a huge difference for the patients in itself, but also from the related family. So what we have heard from professionals working in nursing homes, for instance, is that, of course, sick patients, sick elderly people were not allowed to receive visits from their families because of the cause that the infection could spread. Only when they were really in the terminal phase, having their last moments before dying, family was allowed to say their goodbyes. So what they actually did in a few locations, in a few spots, at least from our research we know, is that the terminal phase was sometimes advanced, so a bit more early. So family was able to visit the patient more early in the last phase and to say their goodbyes to each other when the patient was still conscious. So they really actually could have had a talk. And also another example was that when people die, and in COVID-19 homes, but also in nursing homes, a lot of people died from COVID-19, and they were actually brought away in very impersonal coffins, which has had a huge impact on the residents in the nursing homes, in the patients still lying in the COVID-19 homes. And what they actually did in one location, they made patchworks. And for each person who died, a different patchwork who was actually brought to the family to bring the coffins outside of the home. And it sounds so easily, but what we heard is that there was so much appreciation by all the people working in those homes, and the families in itself, which really made a difference. So coming to, that was actually my last slide. I had one more about what actually brings this to us. What we learned from now is in our current research, we collect all those nice, beautiful initiatives and we try to understand what is happening there and how can we learn from it and what can we use after COVID-19 for it. So I want to invite you to also share initiatives which you have seen or your thoughts about what you have heard so far. So thank you.
Thank you very much, Carina. Some interesting examples of how people take matters into their own hands and do it differently. Yeah, I also appreciated your remark about that organizational and professional interests seem to be less important. So the structuring effects of existing structures and also existing cultures and routines seems to become less tight. It also reminds me of one of the godfathers of transition management in the Netherlands, Jan Rotmans, mentioned related to the COVID-19 pandemic. Crisis is not that bad. Crisis accelerates change, which may be pointing in a similar direction. We have 10 minutes left. What I want to suggest is that we are going to discuss two general questions, just to see what kind of ideas have been raised by this session. I have put them in a slide, but I would like to ask one of my co-hosts to put us all in a breakout room, one-on-one. Because I'm once I moved to my MacBook, I lost the ability to put people into breakout rooms. So, Liedewij, if you are still capable of doing that, can you please do it? Then I will first share the slides and the question, and then you will end up with somebody you know, or maybe a stranger in a breakout room. Discuss this question just for 2 minutes, thinking out loud, generating thoughts, and then we will reconvene here and share some insights. Here we go. This is the question.
Frank, I don't have the rights to put people in breakout rooms. I don't know if...
Is there anyone left that has the right?
Yeah, Laura can do it, and you can just randomly do it. Yeah, sorry.
I think Carina has to do it because she's the host.
Okay.
So,
Carina, you're on it.
Yeah.
The question is, what we've now heard 3 stories. Liedewij's story about engagement in research, Sophie's story about engagement in outbreak response, outbreak management, and Carina's story about engagement in the practice of care. We've already pointed out a few similarities and differences on the way. My question for you now is, what is emerging here for you? What new connections are you making about public engagement? Sevki, you were alone in your breakout room.
Yes, there was no one there, unfortunately.
Well, then
I don't know what went wrong, but
what this webinar made you wonder was?
Yeah, I've heard sort of a bit mixed, like really nice examples from Carina, how this has actually created newer and faster ways to act and perhaps also to engage. patience in this, in creating new structures and creating new solutions to problems, but also maybe that's perhaps more from Liedewij's story, that I think there's also in this sort of crisis situation that people are more likely to see the barriers of patient participation, that takes too much time, and that it's in a crisis situation not the first priority. So these different conversations made me wonder whether it will now be stimulated and fueled, and whether we will see that system innovation happening that Karina was also referring to, or whether it will actually just make it more difficult, and whether it's will go the opposite direction.
Okay, thank you. So this all your the dilemma or the question that you point to also refers to the system transformation aspect. I see that also a lot in the ideas or suggestions mentioned in the chats. So there's a lot of talk about existing structures, building more participatory relationships. Evelien, I see that in your response, for example. Can you elaborate a bit on that?
Yeah, I think what we mostly discussed is the relationship between the importance of existing structures in making public engagement possible in the first place. But connecting that to the question of whether adaptations that we make to those structures or new practices that we invent on the fly, which might or might not be very inspiring in general, and how those structures could be kept for the future. Or not structures yet, they're invented practices.
Can you be a bit more specific? What kind of practices are you referring to? I
think our discussion remained on a rather abstract level. Nina, I don't know if you have something concrete that you would like to add, because it was the two of us that discussed this. You're muted.
No, we concentrated on the process from past, present and future. And we didn't go into specific situations or networks or initiatives.
Okay. Yeah,
I think Frank, the more digital experience that we gained from this period, and how to engage a larger group, and what kind of engagement opportunities does digital engagement offer. I think that's something we can learn from. And I think I've seen in my project, in the Paradigm project, that suddenly pharmaceutical companies engaged and talked with people in a different way, and were able to reach more opinions.
Okay, thank you for explaining that. Esther van Vliet, I saw you raise a hand.
Yeah, I mean, I find it quite interesting what's on the chat now, the discussion of whether people don't want to be engaged, and if that's engagement in itself, or where, like, the whole relation, like, you want to give people the option, but you should also respect the option to be ignored.
And what's your position on this?
So I think it is all about giving options. That's the whole point of involvement, that we open up the doors of, in my case, the ivory tower of academia, to other people. And if they don't want to be involved, I think that's their own decision. But I don't think we can assume that people don't want to be involved because of time constraints or whatsoever. What I've seen in my job with relation to the COVID, when I put out networks for public contributors, I got an incredible response within 10 minutes, and I had to close the ad within half a day, because otherwise I was overwhelmed and I just had to disappoint everyone, basically.
Yeah, so you actually encountered a lot of enthusiasm to become engaged. Yeah, so on the topic of, so I understand that you say you have to give people the options. One thing that I have encountered in my own practice is that people also don't always see their potential or their potential contribution themselves beforehand. So engagement is also a matter of empowerment of people to not only become involved in the sense that they have a way to share their ideas, but also become involved in the sense that they feel connected and empowered and capable of making that contribution. And yeah, so in that sense, engagement is also a capacity building in itself. Is there anyone that would like to respond to that? Yeah, Esther?
I mean, what I've most seen is what really helps giving people explanations. So talking about, so what I've seen in the past, for instance, I got a research proposal for dementia, and researchers wants to have people do an MRI scan for 2 hours, then a 2.5 hour test, and that just sounds horrible for anyone to participate in. And if you come with these really concrete examples, people realize, oh wait, so yeah, obviously that's silly, but apparently people don't realize that. So maybe there is a point in me telling them that something is silly or impractical or maybe not realistic in a real life setting, which is where the public can make a real impact by giving these insights into the researchers they just don't know because they don't have the lived experience.
Yeah. Okay. So that means, yeah, also building relationships for people in order to get used to that idea and be able to share it. I see that there are a few people already moving on to next Zoom or meetings or otherwise. It's already 11:08. So the conversation is unfinished as it should be. I would like to thank everyone for their attention, and especially our three speakers, Liedewij, Sophie and Carina, for sharing their stories and thoughts. And if you are interested in the next webinar, which will focus more on the public debate and the way we make sense about the COVID-19 pandemic, stay tuned. Next Wednesday, 1st of July, 10 o'clock, we will reconvene in this webinar series. For now, thank you all and enjoy your day.